Hello, and welcome to the Texas Rex Educational Series. This session is being recorded and will be posted on the texasrex.org webinars page if you want to review the content or share the information with your friends and colleagues. Today, we have a panel discussion. Our speakers are Jeff Nordyke, Jessica DiLorenzo, Laurie Hooks, and Dr. James Hawley. They will be speaking about quality improvement, bridges to excellence, and patient-centered medical home. All attendees have been muted to block out background noise. If you have questions for our speakers, please raise your hand or post your questions in the chat block of the GoToWebinar pane. Your questions will be read to the presenters, and you will be able to participate in the discussion. Thank you for joining us, and I will now turn over the webinar to Jeff. Jeff, the presentation is yours.
Well, welcome everyone. I appreciate being invited to speak to this audience, and I'm excited to see the turnout. It looks like we have 101 connections attending the meeting today. So welcome, and we will be getting started momentarily. Let's start with an introduction of our panelists. I was invited to speak on the subject of patient-centered medical home and bridges to excellence last October, and my response was, well, I'll be glad to talk on the subject, but I don't know much about it. So I'm happy to report to you that I was able to secure an outstanding panel to participate in today's discussion, and I will serve as the moderator. So let me start by introducing Jessica DiLorenzo. And Jessica, tell us what your involvement is in the quality improvement of healthcare.
Sure, and thank you so much for inviting me to this presentation and this panel discussion. I am a program implementation leader for the Healthcare Incentives Improvement Institute. We're a not-for-profit organization that works to develop recognition quality programs for clinicians that would include physicians, nurse practitioners, and physician's assistants, mostly focused in the area of chronic care. We also do work on programs around episodes of care, data analysis as well. So my role really is to work with all of the stakeholders, including the providers or the clinicians in the community, on program development and recognition in the Bridges to Excellence programs. And I also work with the payers in the programs to institute the incentives, the rewards and recognitions that really provide the benefit to the clinicians to participate. I also work with EMR vendors in the ability to help the data pipelines open up to reduce the reporting burden. So I really work with pretty much all of a multi-stakeholder group. And again, I'm very happy to be here to speak with you today.
Well, thank you. We're glad to have you. Next, I'd like to introduce Dr. Larry Hawley, who is the CEO of Southeast Texas Medical Associates. Dr. Hawley, you want to talk to them about your experience with healthcare quality improvement?
Thank you. I'm delighted to be here. SETMA is a multi-specialty group with 40 providers. We've been using electronic patient records since 1998 and currently hold accreditation as medical home and for ambulatory care from NCQA, a Tier 3, the Association of Accreditation Association for Ambulatory Healthcare, URAC, and the Joint Commission, which you recognize as all four that are accrediting organizations. To my knowledge, we're the only practice in America that has all four. We also have diabetes recognition, heart stroke recognition, and the distinction in patient experience reporting from NCQA. We're also pleased that the Texas Medical Foundation awarded us in 2012 their Texas Physician Quality Improvement Award, and we've just submitted our application for the 2013 and 14. SETMA is heavily involved in inpatient, outpatient, long-term residential care in quality improvement. We publicly report on our website at setma.com on over 300 quality metrics by provider name, and this is our 6th year to do that. We're a Joslin Diabetes affiliate, and we're involved in research projects with Robert Wood Johnson Foundation, the McCall Institute in Seattle, Washington, and with the American Board of Family Medicine. I'm delighted to be here today to talk about all the subjects that we're discussing. We're involved with Bridges to Excellence and have benefited from that financially. And as I said, we've been pleased to be associated with the Texas Medical Foundation and their quality improvement projects. Look forward to participating with you guys.
Thank you, Dr. Holly. We're glad to have you as well. Finally, the last panelist we have is Lori Hooks. Lori is a co-worker of mine at TMF Health Quality Institute, and I'm sorry to report that she's a little bit under the weather. So, Lori, are you able to share a little bit about your background and your involvement in patient-centered medical home?
Yes, thank you, Jeff. I hope you can hear me okay. Thank you for inviting me to participate on this panel. At this time, I'm a senior health services consultant, as you mentioned, with TMF Health Quality Institute. We are the quality improvement organization for the state of Texas, as well as running several other government contracts for both the state of Texas and CMS. I have a background in federally qualified health centers and worked for 15 years on various projects, including Joint Commission accreditation, OSHA, Health Disparities Collaboratives for the HRSA initiatives, and most recently spent several years as Director of IT for the state of Texas, including implementing some health information exchange grants for them. I've moved on to TMF Health Quality Institute and the QIO work, where I've worked on the 9th scope of work as well with Jeff, then went on to head a Health Disparities Collaborative, Salud por Vida, for the state of Texas. That was launched by the Centers for Medicare Services. And then now currently I'm working with the Center for Medicare and Medicaid Innovation in both the SQHC, Patient-Centered Medical Home NCQA initiative, and the Patient-Centered Primary Care initiative, which is called Comprehensive Primary Care for the Innovation Center at CMS. So I'm really happy to be here today to talk about patient-centered medical home.
And we're glad to have you too, Lori. Finally, a little bit about myself. Jeff Nordyke. I have been working with the Regional Extension Center program, leading a team of consultants providing technical services to physician offices. I think our team worked with about 700 physicians across the state of Texas, helping them adopt, implement, and meaningfully use electronic health records. And last estimate was that we helped our clients earn between $10 and $12 million in incentive payments through the Meaningful Use program. As Lori mentioned, she and I are also working on that patient-centered medical home innovation project that Medicare is running currently, and we're working through that program with about 500 physician practices, helping them through a 4-year project transform from their current mode of operation to patient-centered medical home approach to medicine. So with that, let's go ahead and get started with our discussion, and I'm going to call on the panelists to talk about quality improvement, but as we do that, I'd like to encourage the audience to engage with us in this conversation and submit your questions that you may have through the chat panel, or raise your hand as we make a statement that may create some questions in your mind that that you'd like to ask the panel. So with that, let's get started. I think that I'd like to frame this conversation with the idea that healthcare is under intense pressure to do some massive changes right now. Healthcare reform is providing lots of incentive and lots of churn. I think that the quote that I like to refer to is insanity is the definition of doing the same thing over and over again, expecting different results. and that was Albert Einstein's quote. So, the only thing static in healthcare is change. And so what we want to talk about today is how we can make changes to the way we practice medicine that will improve the system, improve for our practice, improve for our patients, and improve for the employees that participate in serving the patients. So let's talk about that. Jessica, let's think about quality improvement from a primary care point of view. Why do they want to engage in making change?
Well, I mean, as we found when we launched the Bridges Excellence program back in 2002, I think every professional on the phone would agree that they go to work every day with the expectation of making things better for their patients. So I think everyone's walking in, and at least my experience has been with the physicians and the practices over the years, is that they want to improve, and part of it is, part of that equation of being able to improve includes a couple of factors that are well-known factors for improvement. We experimented first and foremost, as I said, back in 2002, and became one of the largest national pay-for-performance programs, really to see, first to test the idea of whether or not incentives would help physicians and clinicians in the process of reporting and getting feedback reports so that they would know in the areas themselves where they could improve. And there were a couple of key ingredients that made that program and still makes that program even today very successful, and that would be that there's the use of the clinical data in the program, and it's not based on administrative data. So this gives really that reporting mechanism back in the domain and control of the practice. So it's based on their own practice information and not something that is perhaps handed to them or calculated based on their benefit from essentially several different sources. The other indicator that made it successful was that it is a voluntary program. And there were also incentives and public recognition associated to the program. So there were significant incentives that really helped cover the time and effort that it took the providers to report. And that's important because they're spending their day taking care of patients and not necessarily should be allocating several hours to manual efforts and extraction of data for reporting purposes. So I think those are a few of the key elements that really made Bridges Excellence successful.
Thank you. I heard you talking about data, and in my experience in the past 8 years going out to physician offices and exploring their quality of care, I've found a common theme, I guess it was, that 90% of all physicians say they give above average care. Now statistically, I think that's a little impossible. So Dr. Holly, I know that you are very effective in measuring quality in your practice. You want to talk to us a little bit about that experience?
I'd be delighted to, and I appreciate Jessica's presentation. We have been involved with Bridges to Excellence and appreciate them very much and what they provide as far as incentive and encouragement. The work of quality improvement is difficult. Nationally, we know that the literature tells us that it takes 17 years from evidence-based standards being established before they're generally incorporated into practice. We've got to shorten that time. We can't take virtually half a generation's careers in order to incorporate new quality standards. The other issue about quality is that you can't improve that which you don't measure because you don't know whether you need improvement or not. The standard response I get from physicians around the nation when I have opportunity to speak to them is, I'm doing a better job than the data shows. Well, when you analyze the data and you look at the data and you verify the data, discovered that we just think that we're doing a good job because while we know where we want to go, we don't really know where we are. If you look at a GPS service and you want to go to Detroit and you're in San Francisco, it's a different trip than if you're in Jacksonville, Florida. You've got to not only know where you want to go, but you have to know where you are. The things that's missing mostly in healthcare today is not where we want to go, but where we are. We don't really know because we're not measuring that. We realized that in SETMA a long time ago. We started using the EMR in 1998, and we very quickly realized that we needed to measure by populations, panels of patients, and providers the performance we were delivering in order to know where we needed to improve and how we could improve. Once you know where you are and where you want to go, you can take steps to improve. We've been tracking our mean, mode, and median on hemoglobin A1Cs for the last 16 years. Also, we've tracked our standard deviation. We achieved our goal for the mean, the average hemoglobin A1C, 8 years ago. But we have not yet completely achieved the standard deviation. And so we know we still have a larger population than we want who are not treated to goal. And so we designed projects and goals to improve the standard deviation as well as the mean, the mode, and the median. We use data for a number of different reasons, not only to see where we are, but how we can get to where we want to be. In 2009, when we first got really serious about public reporting, and that was the first year, we've done now, we're in our 6th year of public reporting by provider name on our website for over 300 quality metrics. You can go on our website right now and look up how I treat diabetes, congenital heart failure, hypertension, and so on, and you can see my performance measures. We realized that when we began to look at data, that many of our patients who were treated to goal for diabetes were losing that control in October, November, and December. Well, we surmised that perhaps that was because they were these were holidays and there was food indiscretion, there was decreased exercise, and so we measured to see if the patients were seen less often, and they were. So in 2010, in September, we wrote all of our patients who had diabetes, over 8,000, and we alerted them to the fact that the hazard they faced in that last quarter of the year. We asked them to sign a contract to come see us twice during October, November, and December, be tested twice, and the majority of them agreed to do so. And then in 2011, we went back and measured to see if there had been any improvement, and that incident had disappeared. And so each year now, we can contact all our patients with diabetes in September. We ask them to redouble their commitment to being seen, to being tested, to exercise their dietary discretion, continue doing their exercise, and take care of themselves. And so with the simple analysis of data and information, we were able to institute a rather simple plan that have to improve the patient's care. We think that this is going to be the future because if you can design a program where a provider can measure their performance at the point of care, and they can communicate to the patient in both a verbal and a written form in a plan of care and a treatment plan, how the patient is doing, and some supposition about how they can improve you can actually do quality improvement as an active, ongoing process. In 2008, the AMA, 2006 I think actually, published a project they called Performance Improvement CME. And this is where there are 3 steps. You measure where you are, you do studying to help improve your gaps, and then you remeasure where you are. We've participated in several PICME projects as a practice, and we believe that's really good. We think there's a 4th step, though, and that's having clinical decision support that helps you sustain that over a long period of time. We have quality initiatives that we started 14 years ago that we're still performing at a 98, 99% standard now 14 years later, but only because we have quality clinical decision support, and we have auditing and measurement, and we meet once a month as an organization to discuss how we can continue to improve. The issue with quality improvement is not only to do it, but to sustain it, and I think that's one of the great challenges we have today.
Thank you, Dr. Holly. You've said a number of things that triggered some ideas that I want to get back to. But before I do, let's talk with Lori Hooks for a moment about a number of different approaches to quality improvement. Lori, I know that there's a number of different methodologies, I think PDSA. Can you talk to us about any of those approaches to quality improvement that our audience might be able to research and look at implementing?
I can. There are a number of different ones. One, as you mentioned, that we're most familiar with would be the PDSA, or the Plan, Do, Study, Act, and implementing small cycles of change within your practice to see if those changes might make a difference and might be sustainable. The issue is that you need to measure what you're doing and repeat those measurements over time to see if you're getting that improvement. Many healthcare practices have also implemented something like the LEAN approach. That's L-E-A-N. Those are two very basic ones. There's a lot of information from the Institutes of Healthcare Improvement on utilizing various methods, and that's a good place to get started as well. The IHI website contains some information about their educational practices that you can enroll your staff in. There's plenty of education there for physician and CEO level participants as well. So those are some good places to get started. And when you're thinking about something like patient-centered medical home, you know, understand that it started with a concept. This was a concept that was to assist in the care coordination and care management of very ill children who took a lot of resources of the health care system and also needed tighter management of their cases in order to get better outcomes for the kids. And this is something that, as we translate the lessons learned from that model and move it across the nation into a broader patient-centered medical home model for everyone, we can leverage on all of these different models of quality improvement as ways to proceed and fit the needs of the patient-centered medical home objectives that you're going for, such as care management and working on things like Dr. Holly and what they're doing with his practice in trying to find ways to help your patients improve, try to improve services for them so that they can improve their health. And I really think that every practice should look at what would work for them in terms of what kind of a program. So now we're talking about patient-centered medical home as a program, and I am certified as a patient-centered medical home content expert for NCQA. Joint Commission has a program. There are also several others, and that's something maybe Jessica can speak to a little bit later in terms of incentives and reasons to choose a particular program. But definitely some quality improvement methodology and metric is key in order to participate in this kind of practice transformation.
So, Lori, you made a statement about starting small and testing using data, testing by capturing benchmark or metrics before you make a change, then making a change to test an idea, and then remeasuring to verify whether that was actually an improvement or a reduction in the metric you're measuring. That sounds like more work, and I know that through my visits with physician practices, they are up to their neck in work. Now, why would they benefit from engaging in quality improvement? I want to open this question up to the panel. Why do they need to take on more work when they're already overloaded today?
Well, I think Dr. Holly hit upon it when he said you've got to know where you are. And many times going into physician practices that are embarking on this kind of work for the first time, you do hear estimates that are overestimates in terms of their accuracy in treating the patients as the patients need to be treated. And very often key tests or key information is missed in the treatment of that patient. So we simply want to know where we are in terms of this, and the data is very helpful. Now, on past projects, we would rely on something like payer data. There may be a time delay. It may be the billing data or something like that. We're in an era where now you can really get out of your own database, if you're using an EHR reliably, the information about every patient that you see. And now being able to get your hands on that data, being able to manipulate that data so that you can take a true look at what you're really doing for every patient. And again, you want to start small. You may start with your rates of mammogram, or you may want to start with your rates of flu shot in your medicine practice. You may want to look for how you are with getting your chronically ill patients to come in and get the required tests so you can know where they are and they can know where they are in their health. Choosing something and then seeing that improvement, at first, yes, may be more work, but will also introduce efficiencies so that your patients are getting the care they need when they need it, and that it's appropriate care. And these are things that I think over time, and certainly Dr. Hawley can speak to this, become more efficient and allow you to serve the patient better, help the patient help themselves in a more effective fashion, because now they have their health information and their health data and they understand it, and will introduce some efficiencies and improvements to the health of the patient, and hopefully down the line to the cost, because hopefully those patients will have a better quality of life and stay out of the hospital and the emergency. But ultimately, I think you have to be realistic that at first it may be difficult, it may be more work, but over time that the practice improvements will enhance your life, the quality of your practice, and for your staff, and the lives of your patients.
Let me like to add on to that. This is Jessica. I mean, we've been working as an organization with EMR vendors since 2008. So, certainly the adoption of EMRs and electronic health records has increased significantly over time. This is something that has been happening and is happening for practices where that reporting burden is placed on the EMR vendor. So our role, and my role, is really to work with that EMR vendor on extracting the data from the clinical database that is your data, and to the standards of the Bridges Excellence program, so that you benefit, or the practice benefits, from the feedback report, and there's minimal amount of time spent on any reporting process. Of course, then that creates a dialogue between the practice and the EMR vendor as to where the elements and data elements are placed. But at the end of the day, the EMR vendor is responsible for taking those data extracts, and we're getting a little into the weeds here, but that's how it's been happening and continues to successfully happen for hundreds of practices who would like to participate, at least in a Bridges Excellence program, which again, there are several chronic care programs. So if you want to start out, as Lori was saying, slowly, you can choose a program like diabetes, and the benefit is there is no downside in the sense that when you report, you're given a confidential report and a feedback report at the patient level. None of the scores are shared publicly. If you don't meet the recognition standards, that's only information that you know. It's not shared publicly or with the health plan. And you're going to get that information feedback loop that Dr. Hawley was talking about. That was so important. So that's clearly a benefit. I think the other reason that we also have to be very aware of is that more and more we're entering into an age where consumers are going to be more active in being given information and using these feedback reports and rating systems, and that transparency is taking the shape in healthcare as it does in many of the other service level areas. So, you know, again, being in control of your own reporting and face to the consumers, Bridges Excellence Reporting gives you that option. And of course, the incentives in Texas for practices is a real benefit. So, and I can provide more information on that.
Okay, Dr. Holly, you wanted to say something?
Yes, thank you. One of the things Jeff mentioned is physicians feeling some degree of frustration and fatigue, and that's an understatement. It has gone to what some of us would call as a sense of futility. In the New England Journal of Medicine 5 years ago, there was an article by an internist who said, my quality metrics a year ago were bad, they're bad this year, and they'll be bad next year. She had basically given up and felt that it was futile to try to change her performance. And that's not a rare or an uncommon experience. 3 months after we started using the EMR, I told our staff, I said, this is too hard and it's too expensive if all we gain is the ability to document a patient encounter electronically. If we can't leverage the power of electronics to improve the care that our patients are looking at, both by auditing and analyzing and reporting, and then designing improvement quality programs, and if we cannot measure provider performance and help them improve then this is not worth it. We immediately changed our goal from documenting patient encounters electronically, though we did continue to do that, and we began to design disease management tools, clinical decision support. We began to do auditing and tracking of numerous quality metrics, not intentionally. It wasn't that we started seeing a patient say, now I'm intending to meet this quality metric. It was incidental to excellent care. We determined to treat the patient excellently, and incidental to that excellent care, we were able to aggregate in the background with no effort on the part of the provider to demonstrate that we were meeting the quality metrics, but it was incidental, not intentional. As a result, we then determined to begin to make it easier to do it right than not do it at all. We designed 10 principles in May of 1999, which dictated and directed how we designed an EMR. Now, they just turned out to be, coincidentally, the 10 principles of patient-centered medical home that we learned almost 10 years later when we began to seek NCQA and then AAAHC and then URAC and finally Joint Commission accreditation as a medical home. And this is what's really imperative. Many providers are being asked to squeeze themselves into a pre-designed mold of a EMR that's designed by people who have never practiced medicine, or if they did, their first goal was to stop practicing medicine and have a clerical or administrative or an industrial job because they didn't really enjoy seeing patients. But when you have people that are actually seeing patients every day that are designing the content and also designing the display and the deployment of EMRs, they can make it easier to do it right than not do it at all. One of the things that was said, which is so right, and that is, if you're going to ask people to make a change, they must make a difference. In 1993, IBM was really in serious trouble as a company. They were losing market share. They were losing profitability. They hired a new CEO, and they hired some people called change agents. And one of the principles of change agency, if you will, was if you're going to make a change, it must make a difference. Well, that's what we want our patients to do. And here's the problem. It's very complex. As we ask them to make a change today that will make a difference 30 years from now, how do we get them to sustain that? We can do it by showing them in an analytical fashion, either with things like the Framingham cardiovascular and stroke risk scores or other methodologies, that if they make a change, this is how it will change their risk and will change their future. And when you begin to get dependent upon that and you use electronics, for instance, we do all 12 Framingham cardiovascular risk scores. We add 5 what-if scenarios. What if you improve this to goal and so on? We now have 72 computations. It would take you all day to do those by hand. It would take you an hour to do them by going out to the web and 15 minutes to do them by hand calculator. It takes us less than 1 second to do them. As a consequence, we can do them every time we see a patient rather than every 5 years, as the American Academy of Family Practice recommends. And we can give them to our patients in their plan of care and treatment plan so they can know exactly what will happen if I make this change. It will make a difference, and they're able to sustain it over a long period of time because it's renewed every time they're seen. Electronics are powerful tools. For instance, there are 78 conditions that we're asked to report on to the Texas Department of Health in Texas. I've amused myself the last few years by asking every physician I see, would you just name those for me? Well, nobody can do that. I can't do it either. Well, we deployed them in EMR so that when a doctor makes a diagnosis, it automatically populates that template. It automatically sends a note to care coordination. They automatically report it to the state and then send a note back to the doctor. It takes the doctor no more time than making a diagnosis, and this complex, difficult, imperatively important task is accomplished. That's what we've got to do. We've got to redesign EMRs to where they meet the needs of patients and providers, making it easier to do it right than not do it at all. We believe we can reduce the time and effort and energy expended by primary care physicians by 30%. It would simple redesign of EMR so that they can accomplish tasks efficiently, excellently, and allow us to do all the work we need to be doing while still being patient-centric, doing the activation, the engagement, the shared decision-making, and all the things that are beautifully described in our patient-centered medical home deployments. And the patients love it, providers love it, and we're improving. We're reaching the triple aim. Patient satisfaction is going up. We're decreasing costs, and we in fact are making it sustainable by decreasing that cost, and the outcomes are improving, and they're provable improving because you can go on our website when this phone call is over, setma.com. Look under public reporting, and you can see for 6 years how we are performing. As I like to say, once you open the books on your performance to public scrutiny, there's only one place to hide, and that's in excellence.
Wow, you said a lot. One of the ideas that I kept hearing is terms like efficiency and effectiveness, that the use of technology, specifically the electronic health record, was a friend to your practice, where I hear many other physician practices are just fed up with electronic health records and want to throw it out the window because they feel like it's taking up more time to use the electronic health record to document care than it would the pen and paper. So let's talk about the paradox that you present versus what the experience is with most physicians that are currently adopting electronic health records. Jessica, you want to throw in any comments regarding that paradox?
Well, I mean, obviously I'm not a clinician by trade. I mean, I've heard this comment a lot. Obviously, you know, the incentives in Texas, if I could just talk about that a little bit so folks are aware, participants on the call are aware. The idea of Bridges to Excellence at the beginning was just because there was significant startup time and resources in learning and incorporating an EMR was to provide incentives to do so. And that continues. The incentives really are for demonstrated outcomes in chronic care programs around diabetes, cardiac, and asthma, and they range from Blue Cross Blue Shield of Texas, Aetna, and soon another plan in Texas will also be making an announcement. And all of the incentives are based off of a per patient per year incentive, anywhere from $100 to $150 per patient. In my experience, I've seen clinicians, and I've done implementations anywhere from Boston to Louisville to Colorado to Texas, New Mexico, Oklahoma, and the incentives that are there are pretty significant, thousands and thousands, sometimes tens to $50,000. And what I get a little bit frustrated with, quite frankly, is that I see that it's a struggle and that there's money being left on the table by practices, maybe because of this feeling like it's a hard first step to take. And year over year goes by, and thousands of dollars are being left on the table that could really help that practice make an investment in improving and putting the systems in place to help them improve. And of course, no EMR system is perfect. We all know that. But what I can tell you is that it's being done today, and we've been doing it since 2008, and with EMR vendors sending in data for assessment and accurate assessment, and so that is happening. It is possible, and there is incentive money out there to help make that possible. And the EMR vendors now see it. What I've seen the transition, to Dr. Holly's point, is over time is that they are realizing that this is a value added that's absolutely necessary to their clients and their practices. And of course, PQRS had a big hand in that over time. But they are the ones that we've started out with, such as NextGen, Athena Health, and eClinical Works, and others have been with us and working with us. And just so that you know, they don't pay us, we don't pay them. We're a not-for-profit organization. We have no financial interest in that relationship whatsoever. And we also do not get paid by clinicians for the work that we do. So we're completely unbiased in the development of our programs and the work that we do with the EMR vendors. So I think that opportunity is there.
Let me make a comment. I agree with what Jessica said. I have a personal prejudice, if you will. We're not supposed to discuss our prejudices. I find it far more satisfying and far more potentially beneficial to work on transformation than reform. Reform comes from external pressure, external rules, external regulations, and or external incentives. Transformation comes from an internal ideal. Peter Senge, in his book, The Fifth Discipline, talks about the difference between your vision and your image of what you want to be and the reality of what you are. And he talks about the difference between that being the creative imperative, the creative energy that you're able to bring to bear on a process. We started in 1998. We never received until 2005 a nickel, a dime, a dollar for the use of EMR, for quality improvement. We have yet to ever receive a nickel, a dime, or a dollar for patient-centered medical home. Yet we've totally transformed our practice based on our vision, our ideal, that thing that drives us to get up early in the morning and work hard all day. We put far more money back into our practice. I would tell you what it is, but nobody would believe it, so I will spare you the incredulity and not tell you. But it's far more money than I ever imagined existed in the world that we use every month on treating our patients. The money that we could take home and use for our buying nice cars or whatever else people buy with that kind of money. But we're talking about millions of dollars that we put back into the practice and use for improving and transforming the health care. I think we would be better off, rather than trying to incentivize people with dollars, try to challenge them and inspire them with a vision of what health care can be, which is really what it once was. Because when you really look at patient-centered medical home, largely what we're trying to accomplish is reform health care in a technologically advanced age to be what it was when I was a child in the 40s and 50s, and yes, I'm that old, where there was that patient-centricness because that was about all that the doctor could do. He really couldn't, or she couldn't do much for you. Could do a few things, but largely it was that relationship, that empathy, that compassion. And we're wanting to rediscover that while practicing technologically sound healthcare, which you can't do with pencil and paper, which is a 19th century methodology such as it was. 20th century methodology of healthcare was dictation and transcription. But if you're going to do 21st century medicine, it's going to have to be done electronically, but not with electronics that simply document a patient encounter, but electronics that empower you to do things you could not otherwise do, and that enabled you to do incredible things quickly, efficiently, and at the same time give great personal attention to your patients. I think the design of many EMRs, even the ones that are functioning, are very awkward, and they are not facilitating what we want to accomplish. And it's not to condemn. I'm sold out a long time ago to EMRs. I've spent $8 million of our money. No, there's no no foundation money. There's no government money, out of our pockets, building the tools that we use every day. And they do make it possible for us to do really incredible things. Anybody can do it. It's all on our website. It's free. We don't sell anything. You go on our website, anything there you can borrow. You don't have to attribute it. You don't have to tell us you use it. Just take it and use it and improve your life and improve the care that you give. But
and I believe every practice on the phone has that internal desire to do exactly. I mean, and as I started out the conversation, I say all of them want to do better, and I think the incentives just help with some of those smaller practices that maybe did not have the resources to do that. I mean, our research shows that out of the 50 states, you know, the 14 states where there are incentives, it's the only area that we've seen those 14 states in terms of participating with Bridges to Excellence are the areas that have incentives. The rest of them, from 2002 to current state, physicians and practices are not, nothing has changed in terms of engaging in, at least with the Bridges to Excellence programs, I mean, because that's obviously what we measure. So it's just our point of view, you know, certainly
sure.
that.
I agree with your point of view, Jessica.
Yeah.
We were four physicians when we started. We lost two almost immediately, so there were two of us. When we signed our first EMR contract for $650,000, and our accountant said, "You've lost your mind, you're going to go bankrupt." That was the encouragement we had. I'm not saying that the incentives are bad. I'm just saying ultimately incentives can't lift the whole weight. But heart, vision, passion, personal drive, that internal critical tension, that critical mass, it can. And so it's not either or, it's really both and. But
exactly.
Ultimately the real work's going to be done when physicians, nurse practitioners, and physician assistants get the vision and they have that personal passion. And you don't have to pat them on the back. They're going to drive forward and just have to get out of their way, and they're going to move forward. But Bridges to Excellence, you know we participate in your program. I promote it, laud it. I think it's wonderful, and it should continue. But the ultimate is going to have to be because of that internalization of the professional drive, why people became physicians, nurse practitioners, and PAs to begin with.
These are some great points, and I want to interrupt this conversation because we wanted to engage the audience, and we do have a question that has come in. So, Veronica, you want to read that question out to us?
Sure. The question is from David Dutt. He wants to know, what is the experience with the use of patient portals that are connected to the EMR? How different are the quality metrics for those patients that use the patient portal capability compared to those that do not?
Well, that's an interesting question. I've never considered the quality metrics compared to the use of patient portal. Would anybody like to jump in and try to answer that question?
I don't want to dominate, but we do have a patient portal and we do use it. I think that the patient portal has more to do with the patient-centric shared decision-making process than really fulfilling quality metrics, though I could foresee how it could be utilized to accomplish several things, particularly when you start talking about NCQA or one of the other accrediting agencies for medical home. There are some metrics that relate to your communicating with your patients other than by telephone, and where they can contact you electronically, they can get a copy of their record. So these are important things. I could foresee that could be a benefit. It currently has not been, other than, as I said, increasing the connectivity and the discussion, because now healthcare is at an age where we have to be thinking about our patients and communicating with them when they're not in our presence. In fact, more of our thinking about them and more of our connection with them is going to be outside of an office setting where they're paying a fee for the benefit than it's going to be actually in our office. If you remember, the most important number in healthcare today is 8,760. And I know you all know what that is, so I won't tell you. Okay, I'll tell you. It's the number of hours in a year. If a patient is getting a great deal of care, a lot of care, they're in a provider's presence 20 or 30 hours a year, and that's on a lot of care. So that means there's still 8,730 or 8,740 hours a year that they're not in your presence. So you have to have not only contact with them, they have to have a plan of care and a treatment plan, if you will, a baton they can grasp, take hold of, and comprehend, where they can become responsible, activated, and engaged, so they can become responsible for their care in that interim time. And you can have continued contact with them without them having to make an appointment, without them having to disrupt their lives. So these are the critical issues we're dealing with, not only in patient-centered medical home, but in those non-coordinated practices. We still need to have that contact with patients. And patient portals, secure email, telephone, and other means have to be used in order to secure texting is important to be able to contact our patients and do the kind of intervention and interaction that's going to make a difference.
And Dr. Hawley, I would also add that I think one of the most important measures of improvement, although ultimately we want to see improvement in the health of the patient, but is in that patient satisfaction, because if that is a means by which certain patients find it convenient to access services and get information, there's also some efficiency if they need copies of their labs or their records to take to a specialist or for their own edification. They're not going to be calling your staff 3-4 times and generating calls and callbacks and so forth. And so I think that it can also lend to efficiency. The practices that Jeff and I are working with, as well as many of the practices that I work with in my other program, hundreds of practices, they have implemented sometimes these patient portals, but they're only using them with 10% of their patients, or a certain low number. Not many are using them aggressively or efficiently with a large percentage of their patients. They've been implemented, but I think we've yet to see the value of those in the market.
We're heavily involved in HCAPS and CAPS as far as patient satisfaction and patient interaction. They've been dramatic. We also have a patient, a community council where there are more patients that vote on that than anybody else, so they can outvote us. So we're really engaged in finding out what do our patients think, what do they want to know, not only in a patient-centric conversation in the clinic, but also in these external organizations, CAPS, HCAPS, and CAPS. And those have been very beneficial to us and continue to transform what we do.
Well, all those are great comments about patients' portals. Let's go back to Veronica and see if there are any other questions that have come in from the audience.
No, I don't have any more questions.
Oh.
Not right now.
May I ask a question?
Sure.
I would like to ask Jessica, and she and I have had this offline conversation, so but I'd like to give her a chance to comment about this. What is the potential, Jessica, in the near term to have an insurance company or an organization that's going to pay for patient-centered medical home capacity within a practice or within a group of organizations?
Well, I think, at least from what I've seen over the last couple of years, is there's a great focus on patient-centered medical home from a payer's perspective, and quite frankly, moved away from focusing on chronic care programs. So, there's great potential for practices. In terms of the Bridges Excellence model, we certainly support the NCQA PCMH program structure, and we have a long history of working with them in the development of that program. We offer an alternative medical home program structure that includes the demonstration of a recognition into chronic care recognition programs such as diabetes and cardiac or hypertension that would really serve the population of a primary care practice, in addition to the demonstration of using an EMR vendor in the submission of that data. So it's not an additional application, it's not an additional cost. It is a demonstration of the fact that there, to Lori's point and to your point, that the patient has better outcomes in chronic care and that you're using a system to do that, not the other way around, where you're demonstrating a system that's in place and checking boxes on patient care. And again, we support the PCMH program, and we certainly, it's a very important program. We have a different view on the definition of a medical home, or how it can be demonstrated. And using the EMR, you know, is an important part of that. And so we have several physicians and practices that have reached that Bridges Excellence medical home over time. So, you know, certainly think it's been there's great support from payers around medical home. And I believe that they would get behind it. Our opinion is really is that along with the episode of care analytics that we do that shows reduction in complications of providers that are recognized versus those that are not recognized in diabetes, there are less emergency visits, there's less bed days, and less complications of those who are Bridges Excellence recognized for diabetes. That was the study that we did 2 years ago. So the research that we do is supportive of that type of medical home.
Thank you.
Well, I hate to wrap this up, but it does look like our time has come to an end. I wanted to express my gratitude to all the panelists for participating. Jessica, Dr. Holly, and Lori Hooks, thank you so much for coming on and spending your time, your valuable time, sharing with our audience your experience with these quality improvement programs, as well as how they've benefited your practice, specifically Dr. Holly. Does anyone want to make any closing statements?
No, thank you for letting me participate.
Okay, then.
Thank you very much. You know, anybody that has, oh, sorry, go ahead, Lori.
Yeah, I was going to say I really encourage the practices that are listening to start small and start somewhere, and I've heard Dr. Holly say this on a previous conversation, but his practice is certainly exemplary, but everybody can start and make improvements, and wish you the best of luck.
And I would agree with that. We've seen practices, small practices from Louisville to large practices in Boston, and in Texas, there's been a Bridges Excellence implementation since 2009. So it definitely can be done. And if you're interested in looking at Bridges Excellence, you can go to bte.medconcert, M-E-D, concert.com, and you can view a tutorial, step-by-step tutorial, and learn more. You can register for free and take a look, and certainly reach out if you have any questions for me.
Okay.
And Veronica has put their contact information on the screen, so if anybody has any follow-up questions, feel free to contact us.
Okay, to close, I want to thank our speakers for taking the time out of their busy day to share their knowledge with us. If you have any questions for today's presenters, please email the email shown, and we will make sure you get an answer. Please join us next month for our next education webinar in the series. We will be presenting Omnibus Rule, the changes to BAAs, incident reporting and notices. It's going to be on July 9th, and hope to see you there. Thank you everyone for attending, and that's all. Goodbye.